Welcome everyone. I'm absolutely delighted that you're joining us today for what I think is going to be an absolutely fascinating webinar with two experts who are going to give us their insight into a very challenging 18 months around infection prevention and control, and to give us their insights, thoughts, reflections and tips for the future as we move into what we're all expecting to be quite a challenging winter. So my name's Helen Hughes, I'm Chief Exec of Patient Safety Learning. I'm going to pass to Linda. If you could just give a few words of introduction, Linda, and why you're pleased to be here today.
Yeah, thank you, and obviously thank you for asking me to join you all today. I'm Linda. I retired from the NHS last year. I left as Head of Infection Control for NHS England and NHS Improvement, but I've worked in the NHS for 42 years, and like yourself really, I'm passionate about patient safety, and the links with infection prevention and control just fit together beautifully, and putting the patient in the middle of all of this is the most important element for me. It's about the patients first. So glad to join you today.
Oh, thank you, Linda. And Jay, over to you.
Hi, I'm Jay Turner-Gardner. I currently work at Wirral University Teaching Hospital, which is one of the largest and busiest trusts in Cheshire and Merseyside, and it's actually the largest employer on the Wirral. I've been here for a number of years now, and quite an experience now with COVID and where our journey started here at Arrow Park, and I've also got experience in the past of actually having and looking after the first MERS patient in the UK, which was actually at a hospital in Manchester back in 2013 now. So I'm looking forward to this session, hoping people get lots out of it. And I think the first thing that we need to say is that the patient comes first, and it's about patient safety and how we can actually encourage that patient safety and support our staff.
Thank you. And I think that's the focus, isn't it? Everything that we do is through that lens of whether we're making that difference. So we're going to be drilling down into quite a lot of detail. We've got about 40 minutes as a panel discussion conversation that I'm going to be leading with some questions that we've thought about, and then we've got the opportunity for a Q&A for all the participants. So I encourage you in the Q&A section to come up with any questions that you would like to ask the panel, and to if you like the questions, to sort of click on those so that we can spot the ones that are the most interest to you. So we will have about 2/3 as a panel discussion, and then plenty of time for Q&A after that. And we may be introducing some polls as we go through as well. So if we get the polls out to you and we get the responses, it will be quite nice to reflect on what your thinking is too. So even though we're virtual, we are going to try and make it as interactive as we can. So I'm going to kick off with well, what's it been like? I mean, the last 18 months for IPC practitioners, experts, advisors has been a really challenging time. But how would you summarise the last 18 months, and what are some of the key changes you've seen in that time? So, Jay, may I start with you, and then Linda.
Thank you. I think the main things are that it's the constant change. I think things were changing on a daily basis. The staff support has been amazing. The changes in how we do things, we've changed from what we used to do before, and I think sometimes the IPC was very cut and dry, and we had to think outside the box. We had to start looking at different ways of dealing with things because we couldn't do things how we'd normally done them. Sometimes it was very fast paced. Always a challenge, and I think the main thing is trying to keep calm throughout it all. As I say, think outside the box, try and look at different ways of doing things, and not just doing things because we'd always done them. I think the big thing was, one minute we had a hospital full of patients, and next minute we had half a hospital full, and all the patients that we did had COVID. So everybody had that one vision. It was to look after our patients and keep our patients and our staff and our families safe. So massive challenges, and I think now the challenge is trying to continue with that, because it's not going to go away, and it's how we actually now introduce this into our everyday lives. So yeah, and there's so many things. I think everybody will have a different story. You know, COVID is at the bottom of that story, but everybody's got a different tale to tell, and I think it's worth listening to all of those, because we can all learn from each other's experiences.
So we'll drill down into some of that detail, because I know some of the stories you've got to tell are you know, absolutely fascinating. Linda, that kind of broad overview and your perspective, because obviously you were in a national role and a policy and a leadership role, as well as kind of working collaboratively with colleagues like Jay and others who are right at the front line. What's your reflection?
I think I obviously echo what Jay was saying. It was fast moving and forever changing, and I think all my colleagues in IPC dreaded a Friday afternoon, because that's when some guidance would change, and that was very frustrating for them. I think some of the frustration, I've heard it from many people, is that we now have many experts, so-called experts in IPC, and the experts that genuine are the experts who've worked in infection prevention and control sometimes have been sidelined and felt that we've now got all these experts who know better, or seem to think they know better than the real expert, and probably focus just on COVID. And we all know as IPC practitioners that IPC is an immense subject. It's very wide, it's very broad, it's very deep, and you can't just focus on one element, and you can't just focus on COVID. We've still got other infections, and coming into the winter we can't forget influenza, we can't forget RSV, all these other infections are there. So I think there was frustration within teams, and the people I've spoken to are exhausted. It's been such a long haul for people, and just when we thought, you know, there might be a lull, I don't mean quiet, because we never say the quiet word, but we think that there might be some time to try and get back into some kind of rhythm, things have heated up again. So I really feel for the frontline teams who are working in IPC. I've sat on the outside, we've supported organisations, but I've not been the one who's been at the end of the phone 7 days and probably nights a week, and there was no respite for many of those teams. So I think the resilience of the teams is significant, and how we support those teams as we move forward. There's been some real positive stuff that's come out of it, and IPC teams have grown. Some of the teams we've been working with, there's been frustration in teams that have been small teams trying to manage this alone. I think it really helped to look at resources, look at things differently, support from other areas. So why would you have your expert IPC practitioner doing data entry? You know, we need data entry clerks. We need to think about how we release our specialists to be the specialists and not to do the jobs that everybody else can do, but use them for their specialist knowledge. So
well, you between the two of you set the framework for a really interesting conversation. So let's drill down to some of that, and I'll focus on the hard quantitative stuff, as well as the kind of staff engagement, how people are feeling, the relationship management stuff. So we'll try and get, and culture, and we'll try and get that balance. But I'll start with some of the tangible stuff around data collection, and how did you know what was happening? How were the systems in place around finding out what was happening? How did they work? How did they need to adapt? What did that look like from a sense of, you know, a more traditional way of IPC reporting, which have been presumably quite standardized, quite routine, rhythmic, systematic, and then suddenly in the middle of a pandemic needing to respond to that. So maybe Jay, with you, if I could first, what did that feel like on the ground, and that need for adaptability, and what did you learn by that?
That was like a movable feast, really, because I think especially most acute trusts, we have to report our mandatory organisms, and they have to report it on a monthly basis. And perhaps each trust report internally slightly different, whether it's weekly, monthly, feeding back to your divisions and your teams, and knowing what your numbers are. And then suddenly we needed to be reporting that on a more frequent basis, and that had to then go down the line straight to NHSEI. Because they wanted to know what our figures were, not just what our C. diff was and our MRSA. They wanted to know our COVID figures. So things got very, very complex, and it was having that ability, IT-wise and digitally, to be able to do that in a fast-moving manner, to be able to make improvements, and actually to be able to let people know what our situation was on a daily basis. So it's gone from just one lot of mandatory reporting a month to actually daily sit reps need to be going out. We need to look at our COVID patients that are coming in on a daily basis. Are they coming in because of COVID, or is it with COVID or for COVID? We need to know where are they being nursed, how many beds have we got empty, how many beds have we got available for COVID patients to be nursed in. And then we also then start to look at how much we're now using our IT to support us in looking at, are we actually screening patients when we should be screening them? Do they get screened on admission? Do they get screened after 3 days, then again on 6 days? And actually, how do we get that information to actually improve our results and improve change and the treatment? Because the sooner we can find out if a patient's got COVID, the sooner we can put measures in place to prevent that spread to others. So our data and our electronic systems have really kicked in. But I think we were lucky here on the Wirral because we actually have, we're really good with our digital, how we are digitally, and we're quite advanced. And part of our strategy as a trust is about how we actually improve on that and how we actually engage with our partners. And really our vision is for the future, digital wise, to improve our care for our patients.
And before I come to you, Linda, just to follow up on that, Jay, I mean, you sound like the Wirral is really, as you say, quite innovative, well established in their thinking, and you've got that infrastructure. How were you able to support colleagues in other organisations who didn't have that and were looking for advice and guidance? Did you create kind of networks and communities to share that knowledge? How did that work?
Yeah, there's networks out there, and because the digital sort of part of the trust have their own networks, and because we use I don't know if it's Cerner Millennium, and there are other trusts that use it, and we look at how we can share how we each use it and how we can improve. And share that best practice and what works and what doesn't work, more importantly, because there's no point in continuing to do it if it's not actually adding any benefit to what we're actually doing. But yeah, the digital reporting is massive, and we would have been nowhere without being able to do that, to actually get the changes that we needed in the time that we needed, that we were allowed.
And thanks Jay. And Linda, to you, presumably you and your teams were at the other end of the receipt of those sit reps. Were you part of that program or not?
Not really at that point, Helen. I probably had shifted on, but I know that there's great scrutiny in the centre, obviously, on the data that was going in. It wasn't just patients, was it? It was screening. It was how many cases acquired it, when they acquired it, what day did they acquire it. So there was a lot of data, but I don't think it was always easy to gather from a provider. And certainly some of the trusts that we've been working quite closely with all had a different solution, and they probably weren't as advanced as you're talking about in the Wirral. But things did move on, and certainly one of the trusts have excellent electronic board where they've got the patient board, all the information, and we're able to add into that, with the data screening when the screenings are next due. So there were electronic triggers to try and help staff to make it visually clear. If I walked onto the ward, have they all been screened? Has everybody got the right term? Who needs help? So people don't understand why the data is required. It can be really frustrating. So I think if you know why you're having to provide something and the benefit of providing some data, it makes sense to you. Whereas if you think that you're constantly having to feed a machine a beast 4 times a day, and then there's somebody else phoning for that one, and if we can, as outside or as a system, make it slicker for people, so one person asked the question, because it wasn't only IPC data, somebody would be asking about the oxygen or the number of ITU beds. There was massive requests on organisations to pull the information out, so streamlining and asking, a single point of contact is always far better, isn't it, than having 6 people phone around.
And I think what you're both saying is data is different from information. So if you're flooding or being asked for requests and you're flooding information back, it's how is that helping you, in terms of the analysis and the impact. So presumably some quite important lessons to learn there. And the question that just come up on the poll is about IPC audits, about being effective at preventing infection. So that just triggers my next question really, which is, you know, you'd got these regular audits. This, you know, did they go by the wayside? Did you adapt them? Did you continue? How did you keep the business as usual going with the response to the pandemic? Oh, Linda first. Sorry.
Yeah. I mean, obviously, I don't do the audits, but what we did observe in different teams was we did need to change things. And I'll give a few examples. Just forever checking your commodes every week might not be as significant anymore. So we do lots of things in IPC, in some places, not in all places, that we've always done, and that becomes routine business as usual. But I think if you just you know, if you stop doing everything, then said, what are we going to focus on? Are we going to focus on making sure that people are wearing their PPE correctly, that they're doing their hand hygiene before and after every patient contact? It was probably about slimlining the pack. And some organisations audit absolutely everything, and you know, it's really deep in audit, and other organisations barely do audit. So there's different ways, isn't there, of ensuring that patients are safe. So we might be, I would always like sort of that focus on using your data to drive improvement, not just doing the audits for the sake of doing an audit because you've always done an audit. And people might come back and say, well, the CCG have always asked for that score or something. But if you sit with our colleagues, our commissioners, they would be willing to adapt with you. So sometimes it's being brave, just stopping doing some audits that we probably feel quite confident with doing, whereas we, you know, and it becomes I don't know, I don't want to say our safety blanket. You do it because you've always done it, and you're worried if you stop doing it, you might have an outbreak of C. diff because the commodes weren't clean. But if you've got safe systems of work, we don't always need to be doing all this audit, but we could focus on where our real risks are.
Thank you. And before I come to you, Jay, on how you prioritised within Wirral, I mean, what are the governance issues and lessons for us there, Linda? Because I think when we were talking a few days ago, you know, those prioritisation and changes in systems, that needs a whole organisation ownership of that. So in terms of what you report through to the executive team, and then what might go to a quality and safety committee, everyone needs to be aware and bought into the reason for some of those changes. So have you any reflections on that would guide people, particularly if they need to make those changes?
I think, as you rightly said, if you're going to make the changes, it's making it through the correct route, isn't it? Not just saying, oh, stop, do that. We're not going to do that, guys. But if you've got everyone will have an infection control committee, or, you know, a patient safety committee. So take your decision making somewhere where it's evidence, and you can say we made the decision because of, and it is recorded, and that's why you made the decision. And people will say, well, the CQC will ask that. They won't always ask for that stuff. They'll observe practice and see what's going on, and then they ask you. And if you say we do monthly audits and you haven't been doing them, you're in trouble, aren't you? Whereas if you've actually said we've made the decision to streamline what we're doing, but the governance around the decision making is really important. And I'm sure all of you, the decisions we make all through the pandemic have been, you know, who made the decisions and where were they made were far wider. So whatever process you've got, do it through that route. So if you're an infection control committee, you would acknowledge there that you're not doing it, and then that would be going up through the route, whether you go through the quality and safety to the board, and probably the board aren't going to know about your commode audit, but so it's that kind of what detail is going to go to the top and how the decisions were made, and make them in the right place and record why you've made those decisions, because when you try and look back 18 months, 2 years down the line, you won't remember when and why you made a decision if you haven't recorded it.
Well, hold on to that, because we'll come back to that kind of learning point. But thank you, Linda. But Jay, how did you make those prioritisation decisions to move away from maybe a more kind of routine, standard way, and needing to prioritise, you know, in the pandemic? What was the kind of decision making you went through? How did you do that? What kind of insight did you have from that?
Okay, we learned early on that staff time was really, really valuable, and it was really, there wasn't a lot of it. So we actually looked at what does make a difference with COVID, and we pulled out those things that were especially beneficial for COVID, and we targeted our actual audits on those areas. And there was an audit within the actual, you know, within the audit process on Perfect Ward that we're actually able to use. So we stopped doing some of the audits that actually wouldn't have been of benefit at that time and concentrated more on the COVID app. So things like hand hygiene, PPE, were things clean, those things that were going to make a difference, because COVID was our priority there and then. And I know, commode audits are really important when you've got C. diff, but actually not so much when you've actually need to be looking at hand hygiene and are people wearing masks and are people doing what we need to do to prevent the spread of COVID. So for us, it was able to look at what makes a difference, look at what's of benefit, leave behind that doesn't make a difference at the moment, and actually add on those things that are more beneficial at the moment for our staff and for our patients. And that way we could then, if we had a ward where we had COVID patients, we'd do it more frequently, because we needed to make sure that those standards were being maintained on a regular basis and not just here and there when we did our audits. So they would be done on a more frequent basis, whereas the wards where we didn't have any patients with COVID, they weren't done that frequently. They concentrated on other areas, with always in the back of our minds the fact that actually all of the things that we're auditing for IPC are sometimes important, because we do have our other infections like our MRSAs and RCPs and C. diff and other things. So it's sort of maintaining that standard and that foundation, but adding little bricks onto it for other things that now is our concern at this present time. And that's how we looked at our audits and our audit program. And they were looked at in, daily by teams. They were reported into divisional meetings every month. That reported into our overall infection prevention meeting trust-wide. And they were looked at as really valuable tools, as evidence that we were doing what we were doing, and was it actually helping us or not helping us? And if it wasn't helping, what else we could do and look at that would help and improve our patient safety.
Lovely. Can I pick up a point that Jay made earlier about suddenly there were lots of IPC experts around, in addition to the professional experts that had always been there, and so I want to pick up how were you getting the guidance that you needed? Was that coming through? Were you having to develop that yourself? You sort of said about Friday afternoons, more guidance coming. How did the guidance present itself, and then how did you reflect and use that? But how did you share that with staff who may be working in areas who may not have had a lot of training on infection prevention and control themselves? So how did that kind of guidance, knowledge flow and training work within the Wirral?
So I think it was Linda that made those comments originally.
Yeah.
But yeah, for us, it was always on a Friday afternoon, and it was always just as you were thinking you were going to get off on time, and you thought, oh, here it comes again, and how can I leave everybody with all of this over the weekend? So very much we relied on PHE guidance coming out, and then that guidance was then adopted locally on how we did it ourselves, because it's in recognition that lots of different areas have lots of different competing problems and challenges, and it's how you actually address them locally and what's best for your population and for your staff. So we actually had what we call clinical advisory group that actually meets, and that was all the management teams in the trust, and we would actually all be responsible for looking at that guidance, all digesting it, all trying to actually find out what was of benefit for it, and actually agreeing on that guidance for our teams within the trust. So it was never just me on my own. It was a multidisciplinary team that agreed. I was asked for advice on the guidance and how it was from an IPC perspective, but it actually was the whole team, because I don't think if you've not got buy-in from everybody, then it's never, that change is never going to happen. You're never going to implement that change. And then the way we got that down was cascading it top down and bottom up. So people that were present at that meeting, minutes used to go out. We then developed a newsletter from that meeting, and that newsletter then goes out to all the teams, and there's links how they can click on a link and it takes you to the new guidance that we've just actually agreed on that day. So lots of different ways of getting it out. And then we developed housekeepers meetings and things that would affect the housekeeper from that guidance, like cleaning and storage. Then we let them know that. So every level of the organisation got to know the guidance and how it would affect them. We started doing like crib sheets and reminders, tick lists for ward managers, what do they need to focus on, so that they knew what was happening, because the guidance was so vast You know, right at the very beginning, if you clicked onto the page, you know, the government pages, there's just a little bit of guidance there. If you click on it now, you could spend all day actually going through all the guidance, because there is so much available. Because obviously, as we've gone on, we learn our lessons and we put more things in place. But yeah, communication was key. You know, everybody working as a team, not just the spotlight being on me all the time or on my team all the time, but everybody taking some ownership of that. And then cascading that down to everybody, you know, posters, newsletters, whichever way we could, we got that news out.
Yeah, I was just going to say, oh, sorry, I'm interrupted there.
Sorry, Linda, I was just going to mention that actually it's been reported today in MMJ Open about the Wirral and the multidisciplinary team working on this. So we've just posted that up on the hub so other people can see that. So there's a little bit more information to follow through on that. So well done Wirral for getting into MMJ Open on that. Sorry, Linda, I interrupted. Over to you.
I was just going to say, one of the trusts I was working with during the period had a very good system. So they would have a daily huddle with every directorate, division, whatever you like to call them, were representative. They would just talk about the key changes for the day, the key challenges for the day. Then those people came, then they went back to different areas to cascade down, where they would then have a huddle on each ward or in each clinic to try, and it worked really well. And they, you know, what's the issue today? But it was and that happened every day of the week on every site that the trust covered. As well as, you know, the outbreak meetings, the other meetings, that everybody came in the room from every kind of area of the hospital, and, you know, estates, the cleaning, the medical, everybody was represented, and they could hear that one story from whoever was, you know, directing for the day, if you like, and that worked very well.
Do you think everyone was in that same place, or do you think there are organisations, acute care, but obviously, you know, non-acute care, social care, that could be learning from some of this obviously excellent practice around multidisciplinary team working, communication, engagement, and kind of debriefing reviews?
I think it's obviously more difficult as you move away from acute care, isn't it? And you're getting, so if you're perhaps a community trust or a mental health trust that might have 100 different sites, it's about how you cascade then is very different. But I think at the beginning, our virtual working wasn't that good, was it? We were talking to people who hadn't even got a laptop that they could join a meeting on. You know, they were dialing in still on the office phone. So technology was really quite behind at the beginning of the pandemic. And if you think of then, if you're the independent care home and you're literally on your own, I don't know how that gets cascaded out so easily either through different networks. It wouldn't certainly happen on a daily basis. And it's probably, I think, a point for better working in the future is how do you work as a system? And I think that's the solution to many of our problems in IPC and many other issues, is if we work together as the system, the ICS, whatever we like to be calling it as we go forward. If we've got a network that way, then we are able to support, whether it's from the acute to the, you know, the mental health trust, the ambulance trust. It's so diverse, and then out to health and social care. As a system, a network as a system would be a really robust.
So if you had if you had a magic wand, what would that look like? What would good practice be in creating those effective networks across IPC, across the whole health and social care system? What would you say would be the, I don't know, 3 key things that you would want to establish?
Well, I think we could do it already if we got out of our silos, if you like, because I think we are a bit blinkered, and we think this is me and I work here. Early on, if you think of some work we did pre-pandemic, working on reducing gram-negative bloodstream infections, that was working as a system, and that was getting everybody in that room, from health and social care and the third sector, you know, whether it was looking at hydration of people in, you know, living in their own home. So I think there are some solutions, but we'd probably just need to give a bit more permission to people to say, just go ahead and try it and test it. And because you've taken that step a bit, if you're thinking of quality improvement, because you've done it, if it doesn't work, you can readjust it again. But I think it's because we're employed by different organisations, we seem to have natural boundaries that come into play. Whereas if we were all employed by the one umbrella business, if you like, we probably would go out and work a bit differently. When I started in infection prevention control, I must sound like a really old woman, we covered the whole patch. We worked in mental health, we covered the GP surgeries, we worked very closely with our public health colleagues, and if there was an outbreak in a school or a college, we would go along and support some of that work there. We ended up perhaps working, going to do some water sampling on a cruise ship. We did random things, but it was working as a system together when you'd have your core business to do, but then at times there is that, you need to give some sort of aid to others, isn't it? Mutual aid or support. And I think there could be a wonderful opportunity for somebody to design a system approach to delivering IPC services.
I think so too. Jay, I was seeing you nodding with that. You agree about that kind of, well, you mentioned about the importance of the multidisciplinary team working within Wirral, but the kind of principles apply across the whole system. Is that something that you've been doing within the Wirral, or something that you're planning on doing? What's your reflections on Linda's vision there?
Yeah, I think we do need to share a lot more, I think, because in a way we work in silos because it's what affects my trust today, and I need to sort that out today. I can't worry about somebody else's. But then I think once we can sit back and reflect what we've done, and actually whatever we've done may be able to help somebody else, and maybe what they've done could help me, because not everything we've done here may have been right, but we can learn off each other. And I think it's having that understanding and actually thinking that, it's as long as for me, risk assessment has been a big thing this time. And this, there might be the way of doing it right, and there might be the way that you're doing it and it isn't right. But actually, as long as you're on that road to getting things better and actually improving where you were, then you're making a positive move. And although sometimes it might think that it's a real big challenge to try and get to where you need to go, and that road's going to be very long, at least if you're on that road and walking towards getting better, you're going in the right direction. And I think it's, like Linda says, it's being able to network with people, and network that, things we may do in the trust might not actually be suitable for a care home, but actually some of the things may be, and some of the things might benefit them. And I think it's just trying to get that time. And I think now, in a way, we haven't got any excuse that we don't have time for a meeting, because we tend to sit here all day on our Teams meetings, so you don't have to get in your car and go somewhere now. You can actually just have a quick half hour. What's been your problem today? What can we help you with? And a bit like a troubleshooting, what's your troubleshooting for this week? And just reaching out to other people and offering that help, really.
So how would you, that sounds fabulous. So how would you across, I'm just thinking across the whole system in terms of healthcare, excuse me, say the NHS, but also to colleagues that are joining us from Canada. We know we've got people from Canada and Australia and New Zealand joining us. How are we sharing that kind of insight and best practice? Are there professional journals? What's the mechanism for doing that? Is there something else we can do? I mean, obviously I'm kind of thinking, can we help with our learning platform, the hub? That might be one way that we can but where would you do that and get those models of good practice as we're changing in a very dynamic environment, obviously?
Yeah, I suppose in the UK, it was really good. We've got IPS, which is Infection Prevention Society. So, you join the IPS, they've got their own website. You've got lots of different things that you can learn there. You can post questions, and other people in that network will come back to you. Then there's also the actual we've got a Northwest meeting of the IPS. So there's all different regions that have their own meetings and share their best practice. Obviously, we come together every year and have a conference, which this year will be the first time we've been able to actually get together and have a conference. But it's actually then, how do we reach out to other people in other countries and who have very different challenges to what we'll have? And I suppose that is the next thing going forward. How do we learn from that? There's WhatsApp groups, there's social media, there's lots of things like that. But then it does become enormous. But perhaps that's what's needed, to be able to reach out to those other people. Because what we perhaps think and take for granted here may be something that somebody else overseas doesn't take for granted. And again, vice versa. We can all learn from each other. It's just trying to expand that knowledge, past our shores.
Absolutely. And when I worked at the World Health Organization, I think we I learned a lot that if you're in a resource poor environment, actually you then have to prioritize your resources very effectively. And the way you do that and the way you deliver safe care and your attention to that is different. But there's a lot of insight and learning for better resourced organizations, which is the point both of you made, that, you know, if you get caught into doing the same old as a routine, you're potentially spending a lot of staff time doing that may have less effective impact. So there is a lot of cross-learning, I think, that would be valuable. Now, and talking of resourcing, let's pick up staffing and staff shortages, and whether that was a factor more broadly, but a factor within IPC in terms of the availability of expertise. And we started the introduction by acknowledging the huge amount of work and effort that people have put in, and that they are quite exhausted at the end of a very difficult 18 months or so, anticipating a quite challenging winter with not just a COVID focus, but the other infectious diseases that will be emerging, and maybe you know, with flu. So can you give me some thoughts about the kind of staffing issues and prioritization challenges around availability of staff, but actually how we support staff and their well-being? Maybe with you, Linda, first.
I think all teams need to start by looking at what, if you've got a limited team, I said this before, you need to look at what you really need to do and what somebody else can do for you. So we classically in infection prevention and control teams, they're the doers. So if something needs to be done, somebody's infection control, and they will go off and they will deliver, they will do it. Whereas probably they're not always the best people to do it. So if you're thinking of PPE and fit testing, that's a health and safety responsibility. So then the infection control team will say, well, the health and safety haven't got enough staff, and you say, but have you got enough staff? And it's that kind of it's, you know, you ask a busy person, they do more and more. So I think by honing down what only an infection prevention specialist can do, and they focus on that, you can give away some of these roles, you know, data, even if it's audit, you do not need to be doing some of that stuff yourself. You can use other elements. But I think, as I alluded to the system approach, I think there's benefits if you're thinking of developing teams, and we need to bring people into this specialty. We need to attract staff to want to come and work in infection prevention and control. And we've got massive vacancies in nursing across England as it is. Yeah. And I think that's been reflected now in our infection prevention teams, whereas traditionally we've always focused on a nurse, whereas we need to have practitioners. They can come from a wide range of backgrounds. They don't need to be nurses. So look at where else you could attract people. Classic, you know, your pharmacists to do your AMR work. You know, it may be scientists that are supporting you. Different roles can actually help within the team. And I think to develop the practitioners of the future, it's giving them the opportunities to, it isn't all about just getting your, you know, your qualification at university, but it might be that if I'm working, perhaps I'm working in the ambulance trust, I go and spend some time in Jay's trust to work alongside with the team there, and I go into, you know, meet the lab, the microbiologist, and I understand more. So I think some of the learning that's there is very easy to access if we're given the time to do it, and having a job plan, a development plan for practitioners, so they can move from, you know, the beginning of their journey. Or we might be bringing people in at a different level. They might come over with their, you know, leadership skills, and they need to learn more IPC. So I think we just have to look at things a bit differently, and there is a distinct shortage. If you look in the NHS job site and you type in infection control, you probably get about 9 pages of jobs come up at the moment. And what we're doing, and certainly I live in the south, we're just shifting people around the system, you know, that we're moving people on for perhaps some, you know, rightly so at times for career development, but we probably need to have a harder think about how we develop a service for the future and attract people to work in this specialty.
Yeah,
and not being a policeman, but we're there to improve the outputs for our patients, the quality of care that we provide.
And Jay, how have you seen that at a kind of, you know, at the front line level, where you know, the balance between what you do as an IPC expert and leader, and how you work within that team and the staffing? That, yeah, I mean, you've described a little bit about that before, but in terms of actually managing the resources that you have available, you know, what have been the challenges for you, and maybe what are the reflections as you go into winter that where you need to focus on?
Yeah, thanks, Helen. I suppose staffing shortages have been across the board, really, throughout the whole trust. And I know, we've looked at different roles within the trust and not looked at what staff can't do, but what can staff do. And some staff, like we've had some help from allied health professionals when we've been doing our fit testing, and lots of different people have come to help with fit testing for staff with FFP3 and things. So I think it's, and again, from my own experience of recruitment, because I've recruited new staff into my team, the team's not got any bigger, but we've just had some recruitment, and it's actually doing it a little bit different. So we weren't in a privileged position to be able to get experienced infection prevention practitioners into the roles, but we actually, but we have got people into the roles that were willing to learn, that wanted to know more about infection prevention. And it's been ideal because we now have got people within the team from lots of different experiences. Some have got leadership experience, but no IP experience. Some are junior members of staff, but they've got IPC experience. So it's putting all that together, and actually it's really good basis for a great infection prevention team, because it does need that multidisciplinary level within your own team, not within your own trust, because everybody brings something different to the team. And I think, maybe 3-4 years ago, you would not have interviewed anybody if they hadn't had infection prevention experience. Yet we've found that because we've had to change and do things slightly different, that's actually been a benefit for us. So there are some things that we're taking forward that actually, that will work for us, that obviously we thought it was right before, but it actually has been better when we've changed. And I think, it's looking to what can we offer staff to come here to work, because it is difficult, it is a challenge, and I suppose if we think about nursing on the whole, we had a challenge with MRSA and we thought we'd never meet that challenge. Then we had a challenge with C. diff and never thought we'd meet that, but we did. Then we had CPE raised its head and we thought we're never going to be able to screen everybody for CPE, but we did. And I think COVID is just one of those things in a long line of things that nurses and other teams, they just embrace it and get on with it. We're always busy. I think if you ask a nurse, have you ever had a quiet time? I don't think anybody's ever had a quiet time, because we're busy people, and we find work because there is always something to do. And I think it's just keeping our staff happy, whatever the challenges are and how difficult it gets, and actually realizing that if we can keep our staff happy, they'll keep in work.
And keep staff happy, and it's keeping staff safe, because if staff are safe, then that will contribute towards patients being safe. So putting staff safety and patient safety, we've been describing very much as two sides of two sides of the same coin. And I think maybe in the past, some of us that have worked in patient safety, and I include myself in this, you kind of think staff safety is something's different, and actually it's a much more of an integrated approach, I think, on a kind of safety system approach across the organisation and the wider health and social care system. So I'm going to start picking up some of the questions that are coming through from participants. But before we do that, I just want to give the opportunity for you to reflect. What do you think are the challenges going into this winter, given that we are, back certainly in the UK into aiming to respond to quite a very big elective surgery backlog, huge challenges, and the COVID infection rates are going down, but it's still there are still hospitalizations, and some of those rates are increasing. So what do you think are the key priorities from an IPC perspective going into winter? And let's start with the challenges, and then we might come back to kind of tips for people at how to address them. But Linda, do you want to start with some challenges for this winter?
I think it's that we need to keep our minds open and not just be blinkered by COVID, isn't it? And it's how, when we're assessing patients, whether on admission, we do think of the other risks that go there. And IPC have always been good at assessing at the front door, but as Jay said, you know, we just ended up with hospitals full of COVID patients. So it's remembering those other infections will be coming through, and how you keep the staff, you know, on the ball with that kind of thing. Thinking, don't just think this, could it be flu? Could they have diarrhea? Could it be norovirus? Where I am at the minute, there's a big outbreak of norovirus going on. So these things are happening again. So I think it's keeping aware, and also it's easy. I don't mean it's been easy, that's the wrong word. We have been cohorting lots of patients with COVID. We can't do that with all the other infections. So we've still got the issues in many organisations. We don't have enough side rooms. It's very difficult to segregate patients. We've put pathways in for COVID. So I think we've got a couple of hospitals in England, haven't we, with 100% side rooms, but many hospitals manage with very few side rooms. That hasn't gone away. Those difficulties are still there. And it's how we make sure that if we've got sickness in staff as well, how we cover the important jobs and make sure that we are safe to run, safe to roll, you know, each day at work with, you know, whatever staff group that is, you know, whether it be our, you know, cleaning staff or our portering staff. Everybody, you know, has such an important role to play in keeping the patients safe.
Thank you, Linda. And Jay, what's your reflection? Is that something that you're you know, within the Wirral, you're kind of you've got plans in place, so you're developing those for how you may be addressing what Linda identifies as some not insignificant challenges?
Yeah, I think we need to think of what's worked well in the last 18 months, what has helped us. And I think if you look at it, our hand hygiene, are wearing masks, cleaning effectively, and maintaining social distancing, and they're all very simple things, but we know that they've worked. We know that they've worked here for us. And I think if we look at coming up to winter, we're going to be looking at respiratory illnesses. So actually, well, we actually had no influenza last year. We actually had no norovirus, and we've never ever known years where we've not had either. We didn't even have one case of either. So what were we doing that worked well? So obviously the things we put in place for COVID work well. So let's take that forward. Let's still consider about the use of masks. Let's still consider about social distancing, looking at where we're putting our patients, looking at maybe assessing our patients before we put them on a ward with other people that would be vulnerable if that initial person had an infection. And I think it's keeping all of that in mind going forward. And then we've also, with doing all of our precautions for COVID, we've actually also reduced all of our other infections, which has been fantastic. And that's been a really great thing for the staff to see that those simple things that we've introduced have actually had a measurable, you know, a measurable difference to our patient safety. They've improved it. So why not continue what we've been doing all along? Because it works, because there's no point in doing it if it doesn't work. And I think that's what we'll be taking forward as the winter months come up.
Thank you. And I read somewhere that you've also been, I think, at the Wirral investing in ventilation equipment on wards.
Yeah.
Can you say a little bit more about that?
Yeah, so what we've been actually doing with, well, first of all, I mean, who would have thought that opening your window will actually prevent some infection, you know, so we started off with the basics. So the windows now get opened at least 3 times a day, and we go around and we check that windows are open on wards, and we make sure that doors are open, that the air can flow naturally, because there's nothing better than fresh air. We then looked at some CO2 monitors. So we now actually look at our CO2 levels on our wards. And when our levels hit a certain level, then we start looking at, well, what we're doing, what's any different? Are the windows closed? Is it because we've had a ward round and lots of people have suddenly gone in one area? And what we're in the middle of doing at the moment is looking at all the different areas, what their CO2 levels are. And those that have the highest levels, we've actually purchased what we call as air scrubbers that actually clean the air. So those areas that are having high counts, we're then actually going to make our air cleaner in those areas. And then we are looking, well, we're in the middle of actually doing a big project of looking at the ventilation throughout the whole trust, every single room on every single ward. Is there any natural ventilation? Do the windows open? Or is there any air conditioning? Is there any venting? What are the air exchanges? And then coming up with a plan to improve every single area. That's a massive task just in itself.
Huge. Would you be sharing that more widely, do you think? I mean, either publishing it formally in journals, but making it available to colleagues?
Yeah.
Fantastic.
Yeah, certainly. And I know that the new ventilation guidance has just come out. So, and that's, you know, it's in today's language. and it's understandable, and some very, very good simple tips in there. So for those of you that haven't seen it, then I would recommend you that you get a look at that as well. But yeah, we've got that going forward.
Where would people find that? I'm just thinking maybe we can
put it. Yeah, we can put it on in the chat. Yeah, we'll put the links to it on the chat.
Lovely, and we'll add it to the hub, because we get people access our learning platform from 197 countries so far.
So we'll pop it on there.
Yeah, so if probably people in the NHS know where to get it, but maybe outside they don't. So that sounds.
And in addition, the HSE have published this week, I've been seeing on Twitter, some very simple infographics about ventilation for, that make it very clear that about you need to do this, or it was very helpful for anybody to look at, in your own home, or if you're in a care home, or if you're in, it talks about like the pharmacy where they're perhaps doing the vaccinations in a room without any ventilation, and they've got some very clear infographics on
brilliant.
On ventilation.
Well, we'll share it either in the chat, or we'll follow up with participants afterwards. Perfect Ward are always, they've committed that if there are any questions that we haven't answered, or maybe any future questions, that we'll respond to people. So we'll be able to do that. That's great. I've got a couple of questions. Oh, hang on, one of them's just moved, so I've missed it. Where is it? Let me just check. That go, it moved. Yes, so I'm going to Karen's asked a couple of questions, so thank you, Karen. I think the frequency of monitoring question, I think we may have covered that. We'll come back in detail if we've got time, but I think the question that you've just asked is really quite pertinent, because we know, well, the little I know, that a lot around IPC is about behavioural change, so it's not just about policies and procedures. It's how we make that change in people's behaviour and the safety of their behaviours. And Karen asks, is there staff fatigue with increased PPE usage? If so, how do we tackle that? And 3 people have liked that, so it's a very pertinent question. Linda, you first, and then maybe Jay, if you've got anything to add to that.
I think general PPE, as things stepped back a bit, got quieter, we released some PPE, but I mean, Jay would tell far more about the risk to staff, but people have said that we've been speaking to that it's become a bit more of a norm with wearing a mask. It's like they feel a bit strange without a mask now if you're at work. Yeah. But it has been difficult, and particularly if you think of the heat wave, we're in our hospitals that probably haven't got any ventilation of any sort of air conditioning, so the windows are open, but when it was like 35 degrees outside, so there will be fatigue and there will be exhaustion. It's trying to, I think, ensure that people are wearing it appropriately to keep themselves safe, and it becomes that constant reminder about why you're doing something, and the ability for people to remind others without feeling, that they're going to be in trouble, sort of thing, that you just give somebody a nudge if they see something that isn't quite right. But I'm sure Jay will see every day people who are exhausted by PPE.
Yeah.
What's your thought, Jay, on that?
Yeah, it's a difficult one, and I think, as Linda said, it's making sure that because the guidance does change, it's making sure that staff are aware of the guidance, which is really good. That if we can change how our audits work, so that as our guidance changes, we can inform staff, then we can audit it, so that they know real time, and we're giving them the rationale as to why it's changed. And I think for us here, we've given staff, make sure that they have lots of breaks, make sure they're able to walk away from the area where they're working, make sure they're donning and doffing correctly. We do water rounds, we take cold water out for everybody. We make sure people are getting breaks, and again, we're doing our fit testing. We use the port account machine to do fit testing for our staff for FFP3s, and we're actually now training them on different masks, so that the face isn't having that same mask on all the time and getting pressure points, so they've got alternative masks to use that slightly will feel different on their faces. So lots of things that we can try and do for them to try and ease some of that pressure. And again, it's making sure that it's all backed with risk assessment, and as well. And it's not just about us, it's about our patients. Are our patients wearing masks? Are our patients wearing fluid repellent surgical masks and not just face coverings? Because they've also got a part to play in protecting themselves as well as the staff that are caring for them. So it's looking at it from lots of different views, really. Why are they getting fatigued, and even looking at their areas of where they're working. Can we change where they work? Can they go and work on a ward where they don't have to wear the big level of PPE if it's required? and it's giving them that little bit of respite at times.
So thank you. I've got a question that's come in from Michael Mawini. He says, thinking about communication changes, what have you found has worked best? Many organisations rely heavily on email, and frontline staff don't always get the time to access emails. With information changing so rapidly, what platforms for communication do you think works well? Very pertinent question, you know, that is much wider than the IPC. But yes, how do you engage and communicate with staff in times of rapid change and focus on safety, where, you know, a missed email is problematic, clearly?
Yeah. Who's that one to?
Oh yeah, go on, you, Jay.
All right. So for us here, obviously, if you're a busy nurse working at, you know, at the coalface, then you've got no time to come away from your patients and actually get onto your emails and look at your emails, because you're too busy doing the do. We had a team of people, and we still do, that actually go around the wards on a daily basis and update staff on what's happening. And also it works the other way. The staff can ask them questions that they're concerned about. You know, I don't know about this, what's happening? And that then gets fed back to everybody. And then we can get messages back out into the organisation, because we sometimes take for granted that because we know it, they know it, or because we've told somebody, somebody's told somebody else, and that doesn't always happen. So I think it's looking at different ways that you can do that. And keeping up that communication, and if it doesn't work, like QI, if it doesn't work, look at it again and think, how else can we make it work? Ask people how it'll work, what will their benefit be? Because, you know, it's them that we need to get the communication across to, so they need to tell us how we're better doing that for them.
Linda, reflections on that? Good advice, I think.
Yeah, I would agree. And I think what we have seen in lots of is that safety huddle meeting is really important, that if there's a key message to get over, that it happens through the huddle. And there's there's not a great load of, I don't mean a formal note, but there's key messages taken out of the huddle. If you're not at the huddle, or you're you know, the huddle for the night shift, the message gets passed on. It doesn't just get left in one place. And the huddles where it is the MDT team who join the huddle, not just the ward staff. It would be, you know, the clinicians, the you know, the OT, the pharmacist, whoever happens to be there. So working clinically. Huddles do work with all safety messages, don't they?
They do. And you know, an area that does work, which is slightly more formalized, but, you know, it's a huddle, but it's a kind of like an after action review. So kind of understanding, you know, sort of people exploring, well, what did we expect to happen? What did happen? What, you know, what should have happened? What do we learn going forward? And that kind of after action review framework has been seen to be a very, very powerful driver of safety and quality improvement. So I've got a question from, there's a few anonymous attendees, which is fine. I've got one specifically for Jay. How have Wirral been collecting audit data on IPC? They ask about, is it through Perfect Ward or something else? And any tips for how you're using this audit data effectively during the pandemic waterboard? It's a long question. So what are you changing around data for this winter? So how do you do it? Any tips for using it effectively, and the plan for the future?
Okay, right. Let me try and remember all of those. So it's done, but so all the wards are actually involved in the Perfect Ward, because that feeds into our WISE accreditation locally, and everybody can get on that and have a look at what people are scoring. The individual areas do it themselves, and my team also do it. So we've got a little bit of a you know, to make sure that what we're doing is what the wards are auditing is auditing correctly. We look at undertaking in-depth inspections of our clinical areas. We make sure that the questions that are on our audit are relevant and what they need to be. We actually use our audit tools. Perfect Ward's great because you can take photographs, so you can actually give staff the rationale behind what you're actually saying. So if you say, well, this was like this when I visited, here's a picture, so you can actually see it. So we're able to, you know, give that back to the teams. That's looked at by the wards. Will have their own departmental meetings. All that audit data is actually looked at and assessed, and looked at how then they can put improvements in place, and then they monitor the improvements. Have they been effective? Have they not? And if they've not, then what did we do You know, what can we do differently to make them effective? That all then gets put up to the broader infection prevention control group. And I think it's looking at the data, and we don't want to have 98% all the time, because we know 98% is that perfect number for your hand hygiene audit and from everything else. And if it's 100%, we never believe it. We're going to actually go and do a sense check, because nobody's perfect all of the time. And I think it's trying to get teams to say, if you do an honest audit, even if I would rather have a really poor audit result, because then I know what I've got to work on to try and improve it. And then actually you can actually then applaud the staff for the hard work that they put in to improve it. Whereas if you say you're 98% all the time, how do you then acknowledge all that hard work that the team put in place? So it's starting at the basics, making sure that people are auditing the right things, feeding them back in real time, auditing again to see where there's an improvement, and then keeping that improvement going and keeping on that level. And then going forward for the winter, it's looking at, again, as I say, what's worked and continuing that. And I think, and it's having that, it's having people responsible for doing them. So it's not just a case of, well, like, you didn't ask me for my audit, so I'm going to stop doing it. They need to have some ownership and some buy-in, and that's all about the leadership in that area and making sure that staff continue with them, even though they might not be asked for them, because it's their way of having that assurance from the teams of what their standards are. Because I think as soon as you step back from auditing, you have no assurances, because you can't go on the spoken word. You know, you have to see something, you have to see the standard.
And thank you, Jay. Linda, can I ask you to reflect on that, and the kind of, I suppose, the wider organisational culture of kind of learning and improvement, and the context within which people are working? I mean, having operated at a national level, and from an earlier discussion we had, you know, the real importance of having the right organisational culture to support the initiatives that Jay's just talked about.
I really agree with what Jay was saying. A sea of green in any report is very worrying, and probably is, you know, that would worry me more. If I was looking at a board report that's all green, I just think this can't be reality. So I think it's also giving the teams, you know, not permission, you know, if something needs to be improved, let's score it, let's mark it as it is, and then we can demonstrate that we're using that audit cycle to demonstrate improvement, and using it to drive improvement, not just for a tick box exercise that just gets everyone, oh, I better send that in this month, you know, and there's tick tick tick, and it's looking at it in a real useful way, a beneficial way. And the clinical teams, if it means there's something wrong and they need to, I don't know, it might be that it's something that needs fixing or getting repaired, it often helps them to get the next step in play, doesn't it? If it's that you haven't managed to meet the standard because of, I don't know what it is, you know, something's broken or this doesn't work, you can actually use that to help you get some improvement for the patients, the environment, the staff. So and there isn't one size that fits all, is there? And what you may need to audit in, you know, the critical care unit isn't what you're going to need to be auditing, or ensuring that if you're perhaps working in a mental health unit, or if you're in the ambulance, you know, somebody's put on here that not all infection prevention people are nurses. I accept that completely. Yeah. And the vast majority are. But so you need to look at different things depending on the services that you provide and the risks that go with those things as well. And not get too bound up in all doing the same thing.
Thank you. You know, we've only got about 10 minutes left. I mean, it's just whizzed by, but I've got one question which I think the MDT question that one of our colleagues has raised, I think we've probably covered that, but there is one which is, that might be a bit of a challenge. Which changes to IPC policy and practice were the most challenging to put into place on the front line? That's quite an interesting one. Anybody want to volunteer an answer to that?
Jane had to do it, didn't she? I'm sure she's got
oh my gosh, there feels this last 18 months has been so many rules that I feel I've broken that, you know, prior to COVID you would never have done. So for example, there's a short of alcohol-based gel to decontaminate our hands. So and then we didn't know what we were getting in. So obviously we never actually got the dispensers we never got the refills that fitted our dispensers. So then we ended up with pumps hanging around everywhere, which we didn't want. But then on the back of that, we then actually got 5-litre containers of alcohol gel And actually, how do you get a 500 litre of alcohol gel out to the general public to use who are coming into the hospital, or visitors or patients or staff, when for months we've said, for years we've said, no, you can't decant it. You can't decant it into a smaller vessel. You have to use, it's more expensive, but you've got to have that smaller vessel. It's single use and you throw it away. But then we ended up actually having to decant our alcohol gel into a smaller vessel so we could actually get that alcohol gel out. And they were all different types at the same time. And we always used to say, you've got to always use the one that we've actually bought for the trust, because we can't have you using your own that you've brought in from outside. But actually, what happened? Has anything bad come of it? Has anybody got an infection because we've decanted the alcohol gel into a smaller container? No. And we might find 3 different types of alcohol gel on one ward. Has there been any problems? No. Are people still using it? Yes, they're still using it. And that's what we wanted. We wanted compliance to hand hygiene, whether that's washing them or using alcohol-based gel. And that's one massive thing that, sat really uncomfortably with not only me, but our health and safety. But, it's one of those things. You move on, you have to, things change, and you have to change and think out the box and find a solution.
And I mean, it's coming back to what you said a couple of times, Jay, about the risk assessment. So it may not be the following the perfect guideline, but it's better than nothing. So do it. Yeah. Would you agree with that approach, Linda?
Completely. And I think it might not have only been the hand gel, it was plastic aprons were coming in all different shapes, sizes, rolls, not on a roll, they were hanging on a drip pole, things that you would have said, no, they've got to be in the roll, they've got to be in the container. And then I'd say, this is what's arrived today, because there was that whole thing, wasn't there? You were getting supplies through, but you didn't know what the supplies were. And I think that was a great difficulty, I think, with particularly the FFP3 masks, when the products changed. And Jay's alluded to already, you were fit tested for one mask, and then the next supply may be a different mask completely. And it's they may not even fit the people's faces, have got a very small face, very large face, that was really a challenge for many organisations, fit testing, with the different supplies coming through, and not with knowing what was going to come next anyway. It wasn't like you could prepare for the next wave of masks, if you like. I think things are better now. Jay will be able to allude to that, and the supply is much better when you're getting the same products, but that I think was a big challenge for providers.
Thank you. We've only got literally a few minutes. We've got a very detailed question about chlorine base and cleaning products, which I think, if you don't mind, Sabina, thank you for raising it. We'll probably answer that separately, because we've just sort of run out of time on that. And I just want to draw a few concluding comments based on this amazing discussion. I mean, I've learned so much, and you've both been incredibly insightful and open in your responses, so thank you for that. I hope the participants get some real value from the stories that you've told and your ambitions and what you've learned. So I'll leave the final words with the two of you, but I think some of the themes that have emerged during the conversation really are about needing to be very flexible and adaptable to change. And I think, Linda, you said about keeping an open mind and responding, as you said, Jay, with an appropriate focus on patient safety, staff safety, and the outcome, doing a risk assessment and doing the best you can in what is difficult times. I also thought that it was very compelling about the importance of working collaboratively as a multidisciplinary team and collaboratively across the system, so that lessons learned and improvements could be shared more broadly, so that we try and break down those professional and organisational silos, which are very easy in very large bureaucracies, and they're conventional ways of working. But you've given great examples of why we need to do things differently, and the value and the benefit for patient and staff safety for doing it. And then I think it's about prioritisation, isn't it? When you don't have sufficient resources, about how you prioritise, and you maybe challenge the conventional way of doing things and do things differently, learn, adapt, and if it doesn't work, improve again. So using quality improvement kind of methodology to help drive that change. And then the importance of kind of communication and engagement with practitioners, with experts and staff, so the messages are getting out to the front line. So really strong strong messages and examples of good practice, which I think are fabulous, and I hope people get real value in the details that they've heard, and we can follow up after that. Last couple of minutes from the two of you, if you were going to give kind of magic wand to your colleagues across organizations or across the systems in moving for the future, the lessons that you've learned and that you want to make sure are embedded, that we don't go into a post-pandemic, go back to normal, what would you not want to lose, the strength and the learning and the benefit that has come from this? So 2 or 3 examples apiece would be fabulous. Who first?
Shall I go first?
Yes.
Shall I go first? I was not going to. I think the most important thing is about our staff, and to look after our staff, and they do need downtime. And infection prevention practitioners are their own worst enemies of thinking that they need to be on call 24/7, 7 days a week. So I think you need a really good plan, and you need to cover. You need time out, you need time off, you need to get away from your phone, the emails or whatever. So you do need to look after yourself and put yourself at the front of all this, and trust your team to deliver when you're not there. That's what we have a team for. So make yourself that you're not always available. And I think working virtually, working from home, it takes over your life. So we do need to go into the winter with downtime, and I think that's really important that staff look after themselves, because they need to. They're exhausted already, and they need to make sure they've got time. And I think if we look, people who haven't been in hospital lately, the hospitals have been turned upside down, inside out, and round the wrong way, haven't they? So my own local trust doesn't resemble what it used to look like if you walk through the ED department. So some really good stuff has gone on, and those teams that have worked together to deliver things at really quick pace in the pandemic, estates have been able to turn things around, make an AGP area, and that kind of working collaboratively needs to continue, and really make friends with all the people who you can help and get things done. So they're probably the 2 top priorities for me. Keep doing the good things that worked well, don't lose it all because the pandemic's over. Continue to do that. Brilliant.
Those are 2 great suggestions, Linda. 2 from you, Jay?
Oh gosh, no pressure then. Really, it's so difficult. I was saying, I've said previously that one of the biggest things for me for all of this, because I sit in my office most days now, and I don't get to go out, but I think, the times that I do, I once went to one of the wards, and the ward was changing from being, I think it was from being a red ward to a green ward, or there was some type of transition in that ward, and I went just to check that everybody was okay, that everybody knew what they were doing. And for me, the biggest thing was to see a little man in a bed being wheeled out of the ward, didn't have a single belonging with him. He looked the loneliest individual I've ever seen, with his little eyes looking at me, and I'm saying, "Are you okay?" And he just looked at me, and I just thought, this person isn't a patient, he's a person. He could have been my father, he could have been my brother, and I need to make sure that I do the things, and that my team and the staff in the hospital do the things that keep those people safe, as well as ourselves. Because one day soon, at some point in our lives, we're going to be patients, and we're doing it not just for us, we need to do it for everybody. And I think it's keeping that forefront in our mind. And we do have difficult days, we do have hard days, but I think it's just letting the staff know that they are really valued, and without them we wouldn't be where we are, and our families wouldn't be. And I think that's a biggie for me, and that's sort of all rolled into one really. But I think it's keeping that compassion for ourselves, be kind to ourselves, be kind to each other, because that's what we need to be able to carry on.
Well, I think that's the perfect way to end on your comments, Linda, and yours, Jay. And thank you so much for your time and your insight and your expertise and your compassion and looking after us all. So thank you very much.